start recording.
Great. Well, it's 1 o'clock and welcome to Grand Round. I'm Ian Wilkinson. It's my pleasure to chair today's Grand Round. So before we kick off, can I just make a plug for the Clinical School Annual Distinguished Lecture, which will take place tomorrow. That's Thursday between 5 and 6 o'clock. It's going to be given by Professor Wendy Bickmore, who's director of the MRC Human Genetics Unit at the University of Edinburgh. And she'll be talking about enhancers and their role in human disease. If you want to register, you can do so on the link, which is on the homepage of the Clinical School website. And if anyone can't make the talk, it's going to be recorded and that will be made available after the fact, so you can watch it. Good. So we're just after 1 o'clock, and I think we should probably kick off. As usual, we've got two cases. Our first one is from Royal Papworth, chronic thromboembolic pulmonary hypertension, the orphan disease. And Dr. Seetha Ramaman is going to present the case. Thank you very much. Over to you.
Thank you, Professor Wilkinson, for the opportunity. And I take this opportunity also to thank the organizers of Grand Rounds and Mr. Ang for giving me this chance to present in this great forum. So the topic for this afternoon is chronic thromboembolic pulmonary hypertension, the orphan disease. And as we all know, acute pulmonary embolism is very well known and it's widely discussed. And right from a junior doctor to the most senior person, all are well aware in how to diagnose and manage this patient across the globe. Equally important that acute PEs don't resolve with thrombolysis or anticoagulation, not all of them. A small percentage end up becoming a chronic PE, and these are the subset of patients which end up developing pulmonary hypertension in long run. And it's very important to diagnose this subset of patients and differentiate them from the acute PE because it easily can be misdiagnosed. So why orphan disease? It's because a hematological condition, clinical manifestation happens in the vasculature of the respiratory system. Mode of death is right ventricular failure, and the radiological diagnosis to determine the burden of the disease can be easily missed in untrained eyes. The fix is a thoracic surgical operation done by cardiac surgeons using all the complex techniques available under their experience. And to define this condition, this is a condition wherein the mean pulmonary arterial pressure is more than 21 millimeter of mercury, with a pulmonary vascular resistance more than 2 Wood units and a wedge pressure less than 15, which is important because that rules out any left-sided disease. And equally important and pathognomic is to have an abnormal VQ scan showing perfusion ventilation mismatch. And all these patients have to be anticoagulated for 3 months to label them chronic, to rule out any acute or subacute events with these patients. So with this background, we are going to discuss a case which triggered us to make this presentation and to highlight the importance of distinguishing an acute and chronic disease. So this is a 45-year-old gentleman with previous DVTs in 2011 and 18, who was negative for any thrombophilia screen. And he had a PE in 2016, who was completely anticoagulated. And who gave a history of, at presentation, gradual onset worsening breathlessness. This is more important, gradual onset worsening breathlessness for 3 months, and which significantly deteriorated over at the time of presentation for the last 3 weeks. And he was admitted to Grange University Hospital, where his admission D-dimer was 1280, and the CTPA next day after his admission showed thrombus, which was adherent to his main PA extending into the both pulmonary arteries, looking like a saddle emboli, and echo showed severe pulmonary hypertension with impaired right heart function. And this was the provisional working diagnosis was made as acute PE, and he underwent a catheter-based thrombolysis for 24 hours, which did not make any clinical improvement. And this is the CT scan. If you carefully observe, the PA this is the aorta, and this is the PA with the thrombus, completely occluded right side, and varying level of obstruction on the left side. And if you notice, the PA was larger than the aorta, and the right heart is significantly dilated, which is not the usual case in patients without PH. And the CT was again repeated because there was no clinical improvement in this patient, which showed there is largely unchanged thrombus burden. And in view of his clinical condition deteriorating, he was referred to the referring hospital for them, which was University Hospital of Wales in Cardiff. And he was transferred to their ITU. On arrival, he was hypoxic, requiring higher non-invasive ventilatory support with inhaled nitric oxide. But he was hemodynamically stable at this point. But however, his echo showed poor RV function. Following detailed assessment, he was referred for surgical thrombectomy to their local team, which was rightfully declined because this is a specialized procedure which is not done everywhere, and it is done only in UK. It is only done in Papworth, and mainly it is for the chronic disease. In view of continued deterioration with no options left, the cardiologist there decided to take him for a percutaneous catheter-based thrombectomy, and this yielded chunks of yellow chronic material. And this is when it rang a bell, because all this time the working diagnosis was acute PE, and at this stage they realized the thing what they were handling is chronic and it's not acute. Of course, this did make a difference in his clinical condition. He had temporary improvement, and you can see this is a picture which was taken out during the thrombectomy, and this all clearly says it is chronic. And the mean PA pressure during this procedure was 60 and a systolic pressure of 90. And post-procedure, he made transient improvement. However, subsequent to this, in few hours' time, he required escalation of inotropes, and he was on maximal inotropic and non-invasive ventilatory support. At this stage, this was a Friday evening, and at this stage, he was referred to us for further discussion and management options. And the images were transferred, and our radiologist felt at the right away this was chronic, and the disease was an operable distribution for surgical access. And our team of surgeons reviewed, and they accepted for this patient for surgical management. As a special case, because we don't have a national ECMO retrieval service or transfer service for getting these patients across, being an young patient, our team of surgeons, intensivists, and the ECMO retrieval team prepared to even put him on ECMO if needed. We went from Papworth and retrieved him from Cardiff, and they managed to successfully transfer this patient, although it was a high-risk transfer, without needing any intubation or ECMO. On arrival, the plan was to stabilize him in the next 24-48 hours by taking fluid out of him and offloading him, and subsequently optimizing his inotropes, which was the plan in the intensive care on his arrival, and subsequently doing an endarterectomy surgery in the next 48 hours. Unfortunately for him, he became drowsy on the night of arrival and next early morning. At this stage, it was not very clear whether it was a neurological event or a respiratory event, because he was unresponsive. His gases, mind you, these are patients with chronic PH, and they tolerate hypoxia very well. So hypoxia can never be a driving force. They do tolerate saturation of even high 70s and low 80s and very low PO2s. And because he was unresponsive, it was decided to go ahead with intubation. At this stage, it was very difficult to make any proper clinical assessment. Unfortunately for him, he arrested during intubation, and the CPR was commenced. And this happens with any patients with severe PH and RV failure. That is why these patients have to be intubated as electively in a controlled setup where the surgeons are ready, if they crash, to go on bypass with the chest open. And this is the reason why we didn't recommend intubating this patient in a peripheral center where these facilities were not available. At this stage, our surgeon was contacted, and the plan was to do an ECMO CPR, because with the level of obstruction in the pulmonary vasculature and severe RV dysfunction, it was very difficult to maintain the cardiac output, however effective it can be. So a peripheral VA ECMO was inserted, wherein the venous cannula was put in the neck to drain the blood out of the patient, and then an inflow cannula into the femoral artery in the groin to establish circulation. And this was successfully done. Of course, it took a bit of time. So by end of 40 minutes, we were completely on full circulatory support. And although this event resulted in a severe metabolic derangement, within few hours of ECMO support, all this were corrected. And the next morning, when the sedation was turned off, he moved all 4 limbs and he was responding to command. And as the more clinical evidence of irreversible organ damage, his liver function, renal functions were all preserved. And an MDT meeting was convened between the surgeons and the intensive care physicians and the family. And the decision was to go ahead with an endarterectomy surgery next morning. And if you look at the specimen, this is the one which I will tell you about the surgical details when you do we have a video presentation, and the details we do it in the later half. So just to highlight, this is the specimen which we removed from the right side, and this is the specimen from the left. And these are the clots which we pulled out from the right atrium. And you can very clearly say these are all fibrotic things, and you cannot see any fresh clots in this specimen. And the surgery was straightforward. There was no hiccups in the procedure, and he was weaned off bypass post-procedure. However, because his RV was very dysfunctional, and in addition to that, there's long-standing occlusion of his right PA, which was completely occluded. When we remove the occlusions in these patients, and when there is increased flow, there is high chance of reperfusion injury, and this is a expected complication in this subset of patients. And he ended up having that, and in this regard, we decided it is safer for him to be on ECMO support for a brief period of time until he stabilized. However, the additional surprise which we found in the theater was when the intra-op TOE confirmed there is a PFO, a large PFO with the thrombus in the RA. And when we opened, we did see quite a bit of thrombus, which you see in the specimen picture earlier. And these were like partly adherent and partly displaced. And there was a large PFO. Usually the triad of high right-sided pressure, RA thrombus, and a large PFO leads to paradoxical emboli. And this rang an alarm bell based on his clinical deterioration in the morning, whether it was a neurological event. But at that stage, his pupils were reacting well and his cerebral sats were okay. So we hope that it will be in his best interest, he will recover fine. But unfortunately, after he was transferred to the intensive care in a few hours' time, the ICU staff noted that his pupils were unequal, and CT at that stage confirmed massive infarct with midline shift and herniation. And in view of this, the neurosurgeons were involved, and they felt there is futile and there is no chance of any surgical recovery for him, neurological recovery for him. Although he was cardiovascularly stable and he was weaned off ECMO, in the next 48 hours, his neurological damage precluded any chance of permanent recovery. And hence he was declared brain dead on the next in a couple of days, and the family was grateful to donate his organs for abdominal transplant. And this unfortunate case triggered us to make this presentation, because although we have done all our best to make a difference in his condition, unfortunately that was not sufficient because of this paradoxical emboli, which was not in our control, and it decided the fate of this patient, unfortunately. With this case in background, we thought it will be important to make a distinction between an acute and chronic event and how to manage this patient. Just to recap, the chronic pH is a precapillary thing, and where the mean PA pressures are more than 21 millimeter of mercury, and the wedge pressure is less than 15 to rule out left-sided event, and a resistance in the circuit more than 2 Wood units, which is 160 times. And these patients need to be anticoagulated for 3 months before they are labeled as chronic. And this is a complication of acute PE, and the incidence, if you follow up all the patients with PE, it varies between 0.1 to 10% for them to become chronic in symptomatic PE patient. And the other important factor here is more than 50% of the patient, the first episode of acute PE is subclinical, and they don't even recollect having one. So if you add up these two, there are a significant amount of patients in the community who are having chronic CTEPH. And this is a paper which shows that if all the PE patients are followed up, this was published in New England Journal in 2004, where around 3.8% of the patients had acute PEs, when they followed up for 2 years, their incidence of chronic CTEP is around 3.8 to 4%. And these are patients where they had multiple PEs, larger perfusion defects, and unprovoked PEs. These are the risk factors for them to become chronic. So what is the difference between a CTEP and a classical idiopathic pulmonary hypertension? One, it is the disease of major pulmonary arteries, and it is non-homogeneous because there are certain segments of arteries which are more involved and the other segments can be completely normal. And this is closely associated with venous thromboembolism. And this is the only type of pulmonary hypertension which is amenable to surgical treatment. And in UK, the average incidence is 5 per million per year. And it is the most commonest subset of pulmonary arterial hypertension. Why does PH happen in this patient? We all know acute, if resolves, everything becomes normal, but if it doesn't resolve, it becomes chronic. But why this chronic PE leads to PH? We call this as a two-compartment theory because at the level of obstruction, this increases the resistance on the circuit for the blood flow, and this causes proximal rise in pressure, and subsequently distal to the obstruction, because of increased collateral flow from the bronchial arteries, which are flowing under systemic pressure, which is 5 to 6 times the normal PA pressure, they cause changes in the microvasculature. And in areas where the blood is redirected because of obstruction, in unobstructed areas, because of high flows and high pressure, they causes neointimal proliferation, which causes thickening, and also misdirected recanalization and angiogenesis also contributes to this. Okay, PH happens. Why is it bad? This is because if you look at the cumulative survival, this is the only paper which was published in 1982, where the patients with severe PAH were followed up. And by end of 2 years, patients with severe PH, less than 20% survive. And by 5 years, almost 90% of the patients don't survive this PH. So next we move on to the risk factors to see which predispose acute PE patients to develop chronic pulmonary hypertension. In the first index event, if you see a patient with multiple episodes of previous PE or DVT, those are the ones you need to suspect. Large pulmonary emboli, you need to suspect. And at presentation, if echo shows significant pulmonary hypertension and RV hypertrophy, and these are patients we need to be have high index of suspicion. The other contributing factors can be thrombophilia, hypothyroidism, cancer, myeloproliferative disorders, and long-standing IV lines or pacemakers. They can contribute. This is an algorithm to say you've diagnosed a patient of acute PE, you've managed them, and they have survived the acute event and they've gone home. How do we follow up these patients? It's difficult to follow up all the patients, get them screened for chronic thromboembolic pulmonary hypertension. So it is practically impossible. The easier way is to have a way of communicating with these patients, either by the GP or the hematologist, who under whosoever care this patient is, to see if they are symptomatic after this acute event. At the end of 3 to 6 months of anticoagulation, if they are symptomatic, then we should suspect that something is not all right. And these patients should undergo a TTE, a transthoracic echocardiogram, which is a basic investigation to say whether these patients have pulmonary hypertension or not. If they don't have pulmonary hypertension, then they can be managed based on their risk factors for recurrent DVT. The anticoagulation duration is decided based on that. But if they have pulmonary hypertension, then these patients should have, next investigation should be a VQ scan. Depending on the facility, either it can be done locally or these patients need to be referred to a specialized PH center. In UK, we have 7 centers across the country. Up north, we have got in Glasgow, Sheffield, Newcastle, Papworth, and in London, we have got 3 centers, Royal Brompton, Royal Free, and Hammersmith. So these are the specialized centers where these patients should be referred for management. Once these patients arrive in specialized centers, this is the algorithm which we follow. So we do a VQ scan. If the VQ scan shows ventilation perfusion defect, it confirms the diagnosis of chronic thromboembolic pulmonary hypertension. If VQ scan is negative, it rules out chronic thromboembolic pulmonary hypertension, and other causes need to be thought. The next subsequent thing is to do a right heart catheter to confirm, because echo is always not 100% right in measuring the PA pressures. These patients should be subjected to right heart catheterization to measure their pulmonary pressures. And the CTPA, the CT pulmonary angiogram should be parallelly done to confirm, to assess the extent of the disease burden, and the disease distribution, to see whether this can be, to decide their treatment options. Next, we move on to the next couple of slides. I will be discussing about how to differentiate between an acute and chronic in the CT. So this is a patient with acute pulmonary embolism, where you can see a dumbbell-shaped thrombus, which usually stays in the center of the vessel, and the distal vessels are distended with clots. Whereas if you see, and this again confirms that, and if you see along the line of contrast, because these clots are sitting in the center and the contrast flows all around, they form a concave shaped defect in acute PE. And this is a patient with chronic pulmonary hypertension, chronic embolism with chronic pulmonary hypertension. You can see the aorta is smaller, PA is much more dilated. And these patients will have a web disease. You can see a faint line. And these CTs should be gated. Otherwise, all the webs and things can be easily missed. And you can see this pouch defects because they are all blind ending pouches. And the clot is usually eccentric and they are adherent to the wall. Sometimes they can even be calcified. And this you can see distal to the clot, there is an abrupt change in the caliber of the vessel with distal attenuation, which you don't see in acute pulmonary embolism. And this slide tells us what are the salient features of a chronic pulmonary hypertension. The vascular signs, we saw the acute, the web diseases. The other important finding is the collateralization. The collateralization happens in the distal distal to the obstruction. And this is the most important sign for diagnosing chronic pulmonary hypertension. And the other features are main pulmonary artery will be dilated, and the right heart left heart ratio, the right ventricle is much more enlarged than the left. Usually the left is a bigger ventricle than the right. And the interventricular septum, usually the left ventricle end diastolic pressure is high, so it is a T-shaped septum, but here it will be septal flattening followed by bowing into the left ventricle. In fact, in worse patients, we see the LV is really squashed. The cavity becomes very small. And the most important thing in the parenchymal lung window is to see for mosaic attenuation, which is pathognomic of chronic thromboembolic pulmonary hypertension. And this is a flow chart. So now we have a patient acute. We have followed them up to see who all end up having chronic, and then subsequently we have figured out whether they have pulmonary hypertension. So we have diagnosed them. We have reached a stage where we have got diagnosis of CTEP. Then what we do next with these patients? Then these patients should be referred to an expert CTEP team, which include a surgeon, pulmonary vascular disease unit, and radiologist. So these patients in this MDT meeting, they are assessed for their operability. If they are operable, then they are offered surgery, which we call as pulmonary endarterectomy. And if they are non-operable, they are for targeted medical therapy and balloon pulmonary angioplasty. So irrespective of what we do, either surgical or conservative medical management, lifelong anticoagulation is most important. And the choice of DOAC versus vitamin K is again debatable, but both are equally used, and for the comfort now, DOACs are more preferred. There are no survival advantage over one over the other, but events of acute recurring clots are higher with DOACs. And pulmonary vasodilators are given in these patients to get the PA pressures and helps in RV remodeling. And it can be started pre-op, and in some of inoperable patients, selective cases, we use this. And riociguat is the only licensed drug to be used in CTEP. Before going into this is a surgical video which is going to run for the next couple of minutes. And before we start that, I'm going to tell you briefly about how this endarterectomy procedure is different from any routine cardiac surgery. All cardiac surgery, to do an intracardiac operation, we need a bloodless field. And to achieve that, we need to put this patient on heart-lung machine. Whereas the trick with this pulmonary vasculature is it has dual blood supply. So by putting a patient on heart-lung machine, we can eliminate the forward flow from the PA. But the bronchial collaterals will still be perfused from the cardiopulmonary circuit. So to avoid that, the only way is to completely stop the circulation for these patients. And to achieve that, we cool these patients by putting them on a heart-lung machine, and we cool them to 20 degrees centigrade. By doing that, we get 20 minutes, a period of 20 minutes where we can safely stop the circulation, and then we can perform this operation. And from our studies, we have understood this can be done in 3 separate intervals for about cumulative 60-minute time with intervals of 10 to 15 minutes of reperfusion. And by doing this, there are no increased incidence of stroke rate, which is around 2% for any standard cardiac procedure. And even the PTE operation, in spite of doing deep hypothermic circulatory arrest, is no different. And this is the video of the procedure where you can see the left pulmonary artery is being opened. And we are on a cardiopulmonary bypass, and we are still not on circulatory arrest. So this is the dissection plane being created. Usually the plane of dissection, endarterectomy plane, is in the intima and the superficial media. And if we are in the right plane, you can see the layer we leave behind should be white and it should be smooth. If we have a pink layer, if it looks more pink, then we know that we are in the deeper plane, and the chance of perforating the pulmonary artery is quite high by doing that. And this procedure is done in very few centers worldwide, and there are very handful of surgeons who can safely perform this operation with reproducible results. And it's a bit tricky, and most of it, the learning is by the feel, because you can see the traction is mandatory part of this operation. If you pull harder, you can break the cast. Sometimes you can even perforate the artery. To break it is very difficult to go and retrieve. So you need to have optimal traction, pull and push. So it is over years of experience, your hands are fine-tuned to do this. And currently the dissection is in the lower lobe, and these are the segmental tails which are coming out and which are being nicely pulled out. The entire specimen has now come out, and now you can see the completely cleared. This is the lower lobe, and you can see the lingula on the top here, and the upper lobe vessels. They're all completely cleared of the occlusive material, and the vessel is being sutured. Now, next we divert our attention to the right pulmonary artery. The access is a bit more difficult than the left because it is wedged between the SVC and the ascending aorta. So you have a self-retaining retractor to expose the length of the right PA, and we do the similar maneuver to completely clear the right pulmonary artery. And here you can see a bit of fresh clot is there, along with the chronic thromboembolic material there. Sometimes the upper lobe, we have to create a separate plane because the disease is a bit further down, and you can see that specimen coming out. And this is the entire cast which we got out of the arteries. This is on the right side and this is on the left side. Depending on the level of the disease, if it is proximal, we call it as level 1. And if we find the disease predominantly in the lobar and descending artery, we call it level 2. And in the segmental, we call it level 3. And in the subsegmental level, we call it as level 4. These are the specimens showing the type 1 disease, where you have more proximal disease. These are type 2, where there's at the level of lobar level, and these are at the segmental and subsegmental level. For want of time, I'm going to skip these complications. This is an X-ray just to show how the reperfusion injury looks, and these patients survived, and thanks to ECMO, which is helping us save these patients. We require ECMO in about 5% of our PTE surgeries, and the survival once a patient goes on ECMO is around 60 to 70%. We do venous depending on if it is only a respiratory problem for reperfusion injury, but if you have a pump failure, we may have to put them on veno-arterial ECMO, and also we do this for airway bleeding as well. And most patients require them for a week to 10 days, depending on how soon they recover. And if they do well, there is no difference in their survival rate once they get discharged. This is how we started the first procedure in 97, and we have done about 2,400 odd procedures till date. And you can see our activity is increasing over every year. And when on average, we do about 200 cases with a mortality of 2%. And a stroke rate of around 2.5% and ECMO rate of 5%. And this is the only paper where we have a 10-year follow-up, and thanks to NHS and the commissioners for funding this follow-up program, because no program in the world has this data. And thanks to this paper, now there is increased interest in the surgical community about this procedure. And this shows that overall survival at the end of 1, 3, 5, and 10 years is 86, 84, and 72%. And this was in our first 500 cohort. The second 500, the survival was even better with 91 and 90%. And the next thing what we understood in this paper is post-procedure, if the mean pressures are more than 38 and the PVR is more than 425, they are the patients who have poor long-term outcome. And these patients have to be on pulmonary vasodilators post-op. To conclude, CTEPH is a commoner than thought, and severe CTEPH has poor prognosis if untreated, but amenable to cure by PTE surgery. Earlier referral to specialized centers helps in timely diagnosis and instituting appropriate therapy. And with increasing awareness, we are seeing more referrals, and our surgical activity is increasing. And hopefully we'll be able to make a difference in this subset of patients. Thank you.
Thank you very much. So we've got time for a couple of questions. So one in the chat, why do patients present with acute onset of breathlessness rather than gradual?
So the patients who they do have gradual symptoms. If you carefully elicit history, these patients will have slow worsening of their physical activity. Either their walking distance or the level of going uphill, they will definitely notice some difference, but they start to ignore and they get adapted to that. This sudden acute deterioration from this chronic phase is because of RV failure.
Right. Okay.
And it is very difficult to distinguish this between an acute and the chronic in a patient in a setting in the casualty. The only way you can figure out is whether they had a preceding breathlessness and fatigability. If not, then it should be considered as acute, and the CT imaging will guide us through that.
Yeah. Okay. So you talked about the intimal proliferation and changes that you get in the condition. Does that regress once you remove the obstructing clot?
So this intimal, the dissection plane is in the intima and superficial media. So whatever is macroscopic, we will be able to remove them. But what we don't know is how much is there in the microvasculature. Exactly. That is what decides on the residual pulmonary hypertension post-procedure.
Right. Okay. And is it typical that these patients will have a slightly raised D-dimer when they come in?
It is difficult because once patients are anticoagulated, D-dimer is very unreliable in these patients. It should not be used as an indicator on anticoagulated patient as a marker for acute PE.
Okay. And you said that Riociguat is the only licensed drug.
Yeah, but we do use.
You use other drugs.
Other drugs as off-label.
Yeah. So what? Sildenafil.
Sildenafil, we have got the phosphodiesterase inhibitors. We prefer tadalafil. And then we have got this endothelin antagonist, which is ambrisentan.
Ambrisentan, okay, great.
Riociguat is very expensive. That's the reason we don't widely use in our population.
I'm sure, yeah, absolutely. Great. Well, thank you very much. We're exactly on time. So great presentation. Thank you. And nice videos.
Thank you so much.
Thank you. So great. Okay. So we'll now move on to oncology. Dr. Wong is going to tell us about tumor, young and atypical. Dr. Wong, over to you.
Thank you, Ian. Good afternoon, everyone. My talk today is based on a young patient who presented with a very rare form of sarcoma, and hence the title, which also reflects my kind of poor attempt to include the abbreviation TYA, which stands for teenager and young adults, an age group where there's an increased incidence of certain types of sarcoma. I will present the case, discuss the diagnosis and the rationales and mechanism behind its treatment and the challenges that we face. So this is a 21-year-old chef, previously fit and well, complained of a 4-month history of feeling unwell and right-sided headache. He also has slurred speech and was treated for recurrent candida infection by his GP. He then presented acutely to hospital with the right facial weakness and asymmetry. He said that he can't feel what he's eating and his right ear feels bunged up. On clinical examination, he has drooping of the right angle of his mouth, weakness involving the right frontalis and orbicularis oculi muscles. His tongue was deviated to the right with fasciculation. The impression was that there was involvement of the 7th and 12th cranial nerves, possibly the 9th and 10th cranial nerves, given his symptoms. Subsequent imaging, including MRI head, show as shown here, a right frontal lesion, a right occipital lesion, and also an extradural mass centered on the right jugular foramen, invading the adjacent bones. CT chest, abdomen, pelvis show multiple lung metastases and also a right femoral head metastasis. So the next step is to try to search for the primary tumor and to find a biopsy site for histological diagnosis. He mentioned a possible lump in his testicle, but an ultrasound scan was normal. 2 days after admission, he mentioned a long-standing query Baker cyst on his left leg, but that was never imaged. An X-ray was performed and that was normal. At that time, the ward asked for orthopedic advice about the risk of right femoral fracture. They requested an MRI scan of the right femur. On the 5th day, He had a EBUS FNA of the mass near the left hilum, which was non-diagnostic. And on the same day, he had an MRI scan of the right femur. And incidentally, they can see a mass in the left popliteal fossa, suspicious for sarcoma. So the mass was biopsy, and the histology showed this to be an alveolar soft part sarcoma. At this point, I would just like to give you some background information on sarcoma in general, followed by a more focused discussion on alveolar soft part sarcoma before I continue to discuss the management of our patient. So sarcoma is a cancer of mesenchymal origin. It is broadly divided into soft tissue sarcoma, bone sarcoma, and gastrointestinal stromal tumor. This talk will focus on soft tissue sarcomas, and that has more than 50 subtypes. The graph on the right, as you can see here, was produced from data from the Cancer Research UK, showing the annual incidence of different types of cancer. As you can see, the commonest cancer include those of the bowel, lung, prostate, and breast. Soft tissue sarcoma only represents 0.9% of all cancer incidence, which is around 3,300 cases per year. They are often named after their normal tissue counterpart, for example, liposarcoma, fat, leiomyosarcoma, smooth muscle. Some are named by their histological appearances rather than its tissue of origin. Some examples are shown here. So sarcoma could arise almost anywhere in the body. Examples shown here are sarcoma in the abdomen, in the orbit, and in the right ventricle. Complete excision of tumor in localized disease is usually curative. Radiotherapy and chemotherapy are sometimes given to reduce the risk of recurrence. In metastatic disease, chemotherapy is the only NHS-funded treatment and could be given to improve symptom control disease and prolong survival. Some patients with limited metastasis can still be cured. Response to chemotherapy depends on the sarcoma subtype, and this could range from more than 80% to less than 10%. Some sarcomas are resistant to chemotherapy, such as the alveolar soft part sarcoma. This is a graph I showed you earlier to demonstrate the rarity of soft tissue sarcoma. Alveolar soft part sarcoma is extremely rare and represents only about 0.6% of all soft tissue sarcomas. In other words, about 20 cases per year. So ASPS was first described in 1952 by pathologists at the Memorial Sloan Kettering Cancer Center in New York. Now, described elegantly in the paper, it states that the tumor is characterized by a pseudo-alveolar or organoid arrangement of the cells in relation to numerous delicate endothelial line, vascular channels, and septa. And then it says, with a peripheral row of cells and a central space devoid of organized structure. The latter arrangement was often seen, especially in some of the earlier cases examined, and it was this pattern that was responsible for the term alveolar soft part sarcoma. Just under 50 years after its first description, a characteristic chromosomal translocation was identified, which fuses the ASPS-CR1 gene on chromosome 17 with the TFE3 gene on chromosome X. Almost all ASPS show a non-reciprocal translocation, where there is a loss as well as gain of genetic material. This is in contrast with a distinct type of renal cell carcinoma, which is characterized by reciprocal translocation of the same chromosomes. The resulting fusion protein acts as an oncogenic transcription factor by the DNA binding domain of TFE3, resulting in expression of genes involved in oncogenesis. ASPS typically affect young people with a median age of onset of 25 years, slightly more common in female. They often present with a slow and painless mass, and if discovered early, excision of the mass is curative. Common sites of metastasis are lung, bone, and brain. Patients with limited metastasis could survive for years, but patients with brain metastasis and/or rapidly progressive disease have very poor prognosis. So coming back to our patient, the table on the left shows the sarcoma chemotherapy guidelines from the London Sarcoma Service, which is widely adopted in the UK. The first column shows the sarcoma subtype. The second column shows the disease stage, and the subsequent columns basically show the recommended first, second, and third line treatments. As you can see, alveolar soft part sarcoma, there is no standard therapy. Therefore, the options for our patient are, number one, symptom control only. In some cases, this may be the best option, but often it is difficult to justify when you have a young patient who is otherwise well and is treatment naive. Or option number two is a trial of chemotherapy, but it's widely accepted that it is not effective. Or we could consider some form of targeted therapy. There were no suitable clinical trials for him at the time. We could try the NHS individual funding request, but from experience, this is almost always unsuccessful. Private funding is not an option. Or we could consider compassionate access of an unlicensed drug. In the next few slides, I just want to discuss the rationale behind targeted therapies for ASPS. This picture shows a cancer cell with the membrane receptor tyrosine kinases at the top and the nucleus at the bottom. The fusion protein in ASPS has been shown to cause the transcription of various genes in oncogenesis. But one of the earliest mechanisms described was the increased activity of the MET receptor tyrosine kinase. Activation of this resulted in phosphorylation of proteins involved in downstream signaling via the PI3K, AKT, and RAF/MEK pathways. These in turn could also lead to transcription of oncogenic genes, including the production of various growth factors, which then bind to receptor tyrosine kinases on cancer cells as well as on endothelial cells, promoting cellular proliferation and angiogenesis needed for tumor growth. Tyrosine kinase inhibitors are small molecules that could target these receptors. Now, angiogenesis is a normal cellular response to hypoxia, and this could happen when tumor outgrowth is blood supply. But cancer cells could also induce angiogenesis even under normoxic condition. Consider what happened in this normal cell. Glucose is transported into the cell by the glucose transporter, and pyruvate is produced from glycolysis. Pyruvate then enters the Krebs cycles in the mitochondrion, where it produces 2-oxoglutarate. With 2-oxoglutarate as a substrate and in the presence of oxygen, the enzyme prolyl hydroxylates the hypoxia-inducible factor, or HIF-1 alpha. Now, hydroxylated HIF-1 alpha is recognized by the von Hippel-Lindau protein that causes HIF to be degraded. Note that in the absence of oxygen, HIF cannot be hydroxylated and it is therefore not degraded. The importance of this will be shown later. Now, this is an ASPS cell close to an artery and hence under normoxic condition. Genetically engineered mice with ASPS fusion protein were found to have tumors that express high levels of the monocarboxylate transporter 1, MCT1. Now, lactate produced from distant hypoxic cells are transported into the cell by MCT1, which then increase the pool of intracellular pyruvate. Pyruvate then competitively inhibits 2-oxoglutarate. So competitively glutarate, and such as a result, the prolyl hydroxylate could not hydroxylate HIF-1 alpha. The HIF-1 alpha could then translocate into the nucleus and result in the transcription of genes needed to stimulate angiogenesis, even under normoxic condition. Now, this provides further rationale for the use of inhibitors that target tyrosine receptor kinases on endothelial cells. So, pazopanib is a licensed orally active tyrosine kinase inhibitor with activities against a number of receptors, particularly the receptors of the vascular endothelial growth factor and platelet-derived growth factor. It was studied in the 2012 PALET study, where patients with metastatic soft tissue sarcoma who have progressed after standard chemotherapy were randomized to receive either pazopanib or placebo. It showed that pazopanib significantly improved progression-free survival, but not overall survival when compared to placebo. Now, the problem with rare cancers such as sarcoma is that in order to have enough patients for a large randomized trial, it is often necessary to include various subtypes of sarcoma, as with 40% of the patient in this study. This is unfortunate because some sarcoma subtypes do respond to pazopanib, but this was not reflected in this trial, and as a result, pazopanib is no longer funded by the NHS from 2015. So TKI options, are there any options for our patients? Now, due to the rarity of ASPS, no large randomized phase 3 trial has ever been done. For such a trial to happen, it has been said that it could take as little as 50 years if you get every patient on the planet on trial. Pazopanib has shown activity in ASPS in small study, but as mentioned, it is not available on the NHS. Individual funding requests have never been successful since national funding for this drug was withdrawn. Sunitinib is another TKI approved for use in other cancers and is also active in ASPS, but is not funded. Cediranib is another TKI that has demonstrated promising activity. As it was an investigational drug, it was available for compassionate access for our patient. This shows a randomized phase 2 study of cediranib versus placebo of 48 patients with ASPS. The graph at the bottom shows the percentage change in the tumor measurement for each patient 24 weeks after starting treatment, or sooner if they progress. Those on cediranib, blue, show a median of 8.3% reduction in size compared with an increase in 13.4% with placebo. You may notice that there are two patients here on placebo had a slight decrease in size of their tumors. This has been reported before in ASPS, and I will discuss this a bit later. Now, there are no differences in progression-free survival and overall survival, but this is difficult to draw conclusion due to the small patient number. And also patients who progress on placebo were allowed to cross over to the cediranib arm. So our patient was started on cediranib, and it resulted in reduction in size of some of the metastasis, followed by disease stabilization that's maintained for 1 year after presentation. He tolerated the treatment with minimal toxicity and actually has improved in his symptoms and was able to get back to work part-time. At one point, we needed to, he needed an extraction of a carious tooth, and cediranib was interrupted to allow for the procedure because of risk of bleeding with an anti-angiogenic TKI and to allow for wound healing as well. Now, during the time when he was off cediranib, he developed more pain in the femoral metastasis and the primary tumor. His disease progressed during the 2-month period in his chest, and the intracranial lesion marginally increased in size with more edema. But the symptoms improved after restarting cediranib. 13 months following his initial presentation, he suddenly presented with shortness of breath, hemoptysis, and chest pain. A CTP at the time showed a large pneumothorax. 500 mils of blood was evacuated, and the cediranib was stopped. During that time when he was off treatment, again, his disease progressed, but we can't give him any more cediranib due to the risk of bleeding. So what next? Now, cancer immunotherapy using checkpoint inhibitors has emerged as a new therapeutic strategy in recent years. And I will give a very brief overview here. Immune checkpoints are part of the normal immune system that prevent overstimulation and autoimmunity, but cancer cells exploit these to protect themselves from attack by T cells. This figure shows a T cell engaging a tumor antigen expressed on cancer cell. Now, this will normally lead to a T cell activation and proliferation and emulation of the cancer cells. But some cancer cells express the programmed death ligand 1, which binds to checkpoint molecule programmed death 1, leading to T cell inhibition and tumor escape. Now, checkpoint inhibitors are antibodies that block either PD-L1 or PD-1, and this removes the inhibitory signals on T cells, leading to tumor lysis. Antigen-presenting cells could also present tumor antigen to T cells. When this occurs, it also sends a co-stimulatory signal via the interaction of CD80 or 86 with CD28 on T cells. However, the checkpoint molecule CTLA4 has the opposite inhibitory effect, and this could lead to T cell inhibition and tumor escape. Again, CTLA4 could be targeted by a specific antibody that stimulates immune cells against tumor antigen. A number of checkpoint inhibitors are effective and used routinely in some cancers. Now, one of the important things about checkpoint inhibitor therapy is the identification of tumor-related biomarkers that could predict a response to treatment. Now, one classical biomarker is the tumor mutational burden, as shown in this figure. A hypermutated tumor will generate more tumor neoantigens, to trigger an immune response, compared with tumor with low mutational burden, which unfortunately is the case for most STS. Another biomarker is the deficiency of the DNA mismatch repair mechanism in some cancers. This could cause uncorrected DNA replication and produce a number of DNA fragments manifested as microsatellite instability. And these could act as neoantigen to stimulate immune response. Again, this is rare in soft tissue sarcoma. A high level of PD-L1 expression on tumor has been shown to be predictive of treatment response in some cancers, but not in others. And the results for sarcomas are also conflicting. The evidence for the benefit of checkpoint inhibitors in sarcoma is lacking, as studies are small and with inclusion of different sarcoma subtypes and various treatment regimens. Now, a recent meta-analysis show a poor objective response rate of 14%, with the best response when combined with chemotherapy or a tyrosine kinase inhibitor. The graph on the right shows the subtype of sarcoma with partial or complete response to checkpoint inhibitors. The red vertical dashed line is a predefined cutoff in the paper of 15% response rate. So any point to the right is higher response rate. Now, as you can see, the undifferentiated pleomorphic sarcoma, UPS, and alveolar soft part sarcoma, appear to have a much higher response rate compared to other subtypes. Just to say that the last on the list, CKS, is actually the HIV-associated Kaposi sarcoma. It is an entirely different entity and is not considered part of the standard management of tissue sarcoma. Now, some potential mechanisms have been suggested to explain the response of ASPS to checkpoint inhibitors. Disease stabilization or tumor regression without treatment has sometimes been described and suggests a role of immunosurveillance. Indeed, we have patients with a small but confirmed lung metastasis, that have been stable for many years. The breakpoint where ASPS-CR1 and TFE3 where the fuse has been suggested as a possible neoantigen and could elicit an immune response. And TFE3 also has a role in immune activation. Now, so far, no reliable biomarkers of response have yet to be identified in ASPS. So checkpoint inhibitors, the largest study in ASPS was on the anti-PD-L1 antibody atezolizumab with a response rate of 37%, lasting for a median of 16 months. There was also a case report showing a very impressive complete response of metastatic ASPS in this young patient with a combination of nivolumab and ipilimumab. As you can see, the scan here with complete response of the lung metastasis. And these apparently persisted for at least 3 years. This is a study of combination therapy with the tyrosine kinase inhibitor axitinib and the anti-PD-1 checkpoint inhibitor pembrolizumab. It involved 33 sarcoma patients with 12 with ASPS. As shown in the bottom graph, patients with ASPS show a more significant change in tumor burden compared with other sarcoma subtypes, and some have quite a long duration of response. This regimen may be the way forward, although at the expense of greater toxicity, but certainly more work is needed to identify reliable biomarkers to predict treatment response. So this is my final slide, and we have come back to our patient. So he was treated with atezolizumab, again obtained via compassionate access. Another point to mention was that he had been suffering from troubling headache since his disease progression, but the symptoms settled with dexamethasone, which reduced the edema around the tumor. There's a concern about immunosuppressive effects of the steroid on the efficacy of checkpoint inhibitor therapy, but we were unable to wean him off, so he stayed on the smaller dose tolerable at 1.5 milligrams daily. Now, 2 months into treatment, his disease was fairly stable, so the treatment was continued. However, 2 months later, his scan showed disease progression with development of new metastasis and a new partial thrombus in his IVC, and his treatment was stopped. Sadly, he died a month later from hemorrhage from the brain metastasis, 19 months from initial presentation. Now, it's not the happy ending that everyone had wished for, but for someone who presented with extensive metastatic disease from a rare cancer for which there's no standard and NHS-funded treatment, I think we have achieved something by keeping him well for that period, so that he was able to spend quality time doing the thing that he liked as a young person, and spend time with his girlfriend and family. Thank you for your attention.
Thank you very much. We've got time for a few questions. First one here, of what are the characteristic PAS positive crystals composed?
I don't know, actually. That's a good question. That's kind of a very pathology-based question, I would imagine.
Okay.
No, sorry, I can't answer that question.
I mean, to what extent do you think that initial combination therapy might be helpful compared to sequential monotherapy?
Yeah. I mean, I think it would be helpful in certain cases where you want a rapid a response, either to control symptoms or to try to avoid, say, compression on the critical structure. But I mean, it may not necessarily be the best way of doing it, because a lot of these patients, assuming that they have extensive metastatic disease, the aim is really to try to keep them alive for as long as possible. And the argument is you could try sequential treatment, one at a time. If they progress on one, then you can try the next one. I mean, for routine soft tissue sarcoma, there's this tendency of using combination chemotherapy, as say, if you want a really fast response, for symptom purposes. But the evidence, at least in chemotherapy anyway, do chemotherapy upfront does not improve kind of long-term survival.
I mean, I was more thinking about targeted therapies, and if you combined, you prevent resistance.
Yeah. I think
which is a feature of some of the other kinase inhibitors, that you get resistance as the tumor mutates around the active site.
Yeah, I take your point. I think a lot of I think there's still a lot we still don't understand. As you can see on some of the trial study earlier, that there are a lot of kind of variability in terms of response to treatment. So I think one of the things is, we still need kind of very reliable biomarkers to find out why some patients respond and some patients don't.
Yeah, I completely agree. I mean, my other comment would be that for a cancer that's going to take you 50 years to do an RCT, it strikes me that you ought to be making use of the ultra rare designation by European Medicines Agency, or MHRA, to get a license without doing the formal RCTs, which may, of course, influence NICE. They make you register the data and keep them updated, but it is a way of avoiding RCTs in very rare diseases. Right, so the crystals are composed of accumulated MCT1 protein, which is chaperone protein.
Thank you, Jim.
147, right, great, thank you. I've been educated.
Yeah.
Good. Okay, I think we're about done. So I'd like to thank both of our speakers for 2 excellent cases. Unfortunately, no happy ending for either, but really illustrative of the excellent work that's going on. And just to remind everyone about the Clinical School Annual Distinguished Lecture tomorrow, 5 to 6 o'clock. Thank you all very much indeed.
Thank you very much.